welcome to this breakout. There are three of us. I have a sister company called Atlas Billing Company, the purpose of which I'll explain in a little bit and give some background. I used to run that completely until I surrendered and admitted my inadequacy and hired Kylie, who is sitting over here. So she's here to help with the Q&A because she really is down in the weeds of what Atlas is doing. And after I describe what Atlas does and how it does it and the extent to which it has begun to spread, you probably will have questions. So we're going to go short on the presentation time and long on the question and answer time. That's our plan. The two areas where free market naysayers will throw their most wicked spitball that free markets can't work in this industry is maternity and emergency care. So we just thought we'd give you a presentation on how the free market is not just, it's being applied right now and has been for some time to maternity care and emergency care. And here to represent the emergency care side of the free market is Christion Rice. We work together. His crew is here from OKER with him. Surgery Center of Oklahoma works very closely. We kind of have a love affair for each other. We love OKER, and I'm pretty sure they love us, so it really works beautifully. But yeah, you're in for an enlightening presentation, I think. Okay, so maternity care can't be bundled. Well, obviously it can. We're doing that. Atlas Billing Company is a medical clearinghouse. Basically, it's a payment clearinghouse that accepts all of the payments for procedures done at Surgery Center of Oklahoma. It's a little bit oversimplified, but that's true. So if a beneficiary of a self-funded plan or an individual or a member of a cost share pays for a surgery that is performed at Surgery Center of Oklahoma, they pay Atlas Billing Company. Those funds then are dispersed by Atlas to the participants in the care episode, whoever they are. That allows for some very powerful things to happen that are not, I think, intuitive. I love talking about Atlas because it's actually more disruptive than I had any idea that it would be. I mean, a lot of things that Jay and I have done have been disruptive, and we knew they would be. Atlas is actually surprisingly disruptive. So years ago, when we posted our prices, I was approached by a hospital administrator from Deaconess Hospital in Oklahoma City. And I was very suspicious about this meeting. Why would a hospital administrator want to meet with me, of all people? And she said, I love what you're doing. I know that all of the administrators in the country know this is coming and it's inevitable. It's just a matter of time. And she then said, is there anything I can do to help you? And boy, did my radar go up. And I said, well, yes. As soon as we put our prices online, patients started coming in from all over the country. And I said it would be nice to know that they could have an inpatient place to sleep it off if they needed more than a day that we could provide overnight. And she said, well, yes, we could do that. And I said, can you give me a per day, per diem price? And she said, yes, we can do that. I was shocked. And then she said, is there anything that you can do to help me? And I said, well, do you have the ability to give me pricing if I ask for it? Because I said, we're getting requests for procedures that we cannot adequately or appropriately perform at Surgery Center of Oklahoma, robotic, this or that, you name it, colon resections, brain tumors. And she said, yes, I can give you pricing. So at that point, I knew the anesthesiologists at Deaconess Hospital. I knew who the surgeons were who were going over there, so I could just call them up and I would ask them the question, that I ask all of our partners when we posted our prices, how much do you want? And so the hospital, when we asked them how much they wanted, they gave us an answer. And they actually delegated this to someone who had a formula. And how much do you want for a robotic prostatectomy? How much do you want for a robotic sacropexy or a colon resection? And just on down the list, nuclear medicine studies. So we had this list of prices. And then at one point I said, can I assume these prices are good going forward unless you tell me otherwise? Yes. Okay. So now I had a list. I knew the anesthesia guys, and then over time there's a pattern, and I know how much the anesthesia guys should charge. And sometimes we would get a crazy answer, and I'd have to rein them in because anesthesia is the worst in these bundles. And I'd call the surgeon and ask them how much would they like to be paid for. It just blew their mind, to ask that question. So we start putting these bundles together, and employers would call, Jay's clients, for instance, HealthSmart's clients would call and say, we have, this patient that has this condition, can you help them? Well, the employer would pay Atlas. Atlas would pay Deaconess and the anesthesia crew and the surgeon and pathology and whoever else. And in our meeting that I had with this hospital administrator, she said something I did not understand until much later. She said, I'm happy to do this as long as you go get all the money and you pay everyone, including her. Well, the reason for that is she wanted no part of the retaliation she would receive from the carriers if they knew she was extending this kind of pricing to me. So Atlas can cloak and is cloaking the participation of hospital systems in this free market movement. So when anyone ever says, well, why isn't this movement bigger or more widespread than it is? Well, it's much more widespread than anybody knows because so many of these folks are in the closet and they're being cloaked by this clearinghouse called Atlas Billing. So we're buying, how many vendors do we have? Hundreds of vendors. So it's not just Surgery Center of Oklahoma anymore whose payments are processed by Atlas Billing, but Atlas has allowed us to go to cardiac hospitals, spine hospital, full service hospitals and negotiate these bundles and not really negotiate. We just ask, how much do you want? So there's another website I would urge you to check out. It's atlasbillingcompany.com, and there you will see listed inpatient pricing. What you will not see is at what facility it is being done, and that's intentional. So if someone calls and they need this or that, we will connect them, but we don't advertise that this bundle is associated with this or that facility. And so that now you know why. So the most difficult bundle by far to manage is maternity. The same hospital administrator, when I called her back and I said, well, this is going well. Are you interested in maternity referrals? And she said, we can't bundle maternity. And I said, well, yeah, I think you can. If you think of it like a toll road with exits, the price for which is known, and just price those, and then forget about the 6-month NICU baby. Just forget about it. That's why God made insurance. For all the uncertainty. So on the Atlas website, you'll see vaginal delivery with epidural, vaginal delivery without epidural, C-section with epidural, C-section for twins. You'll see all this maternity care, but those are like toll road exits, to not for call it anything else, that have a price attached. There are a lot of moving parts to the maternity bundles, but that's how it's done. So, the folks who would like to say, there's too much uncertainty, to manage maternity, how do you manage maternity or how do you manage emergency? And Christian's going to tell you in a minute how you manage emergency, but that is basically how we do it. There are a lot of moving parts because in maternity bundles, you also have the pediatrician many times who is attending the birth and you have to get them paid. And sometimes the one you usually pay is not the one who's there. It's his partner or even his competitor who's backing him up on call. So there are some moving parts, but the maternity stuff is actually very, very doable, particularly now that Kylie is here. I struggled with maternity. I got through it, but even I could do it. If I can do it, anybody can do that. And you all stop if you have questions at any point. Atlas is now in 5 states.
Correct.
So we're managing, creating bundles. My friend Greg Smith calls that curating bundles. I kind of like that. So we create these bundles. We try to figure out if they make sense from a market standpoint. If they do, we post those on the Atlas Billing website. It has also been a very powerful tool to prevent balance billing because attempts to balance bill patients end up on Kylie's desk. So Atlas basically serves as the guarantor, and anyone that decides to get out of line, if they balance bill, they really have, like an anesthesiologist, for instance, they really have to answer not only to Atlas, but they also have to answer to the other members of the bundle whose balance billing the whole arrangement jeopardizes. So they're in sort of a kumbaya, whether they like it or not. And so there's a real check on the balance billing that Marty McCary and some others have written about that's just devastating for patients. So I'm going to stop there. I think hold your questions about Atlas maybe, and I'm going to turn it over to Christion. Christion brought his sexy Barry White voice today. So it's all yours. So here's how ER is done. Here you go.
Okay. Good morning. So let's go down the rabbit hole. Okay, so I'm going to talk about OKER in Hospital. It's one of the hospitals that I help manage. I'm a managing partner. I'm an emergency physician, still work clinical. This is an example of OKER Hospital. These are 3 pictures from the facility. The point of my discussion is to prove or to dispel the myth that you can't bundle or direct contract through emergency room. And traditionally, like Dr. Smith said, it's been a challenge. It's kind of been the narrative when people challenge free market principles. Well, that breaks down when you talk about emergency room care. That breaks down with maternity care. So I hope this example helps dispel that. So the agenda, we're going to talk briefly about the problem with emergency care from a market standpoint. And to do that, we have to talk about the U.S., the national market. And then we're going to talk about things that are more specific for emergency room services. And we're going to show a free market solution. So I'll go through OKER and Hospital and show you some of the bundling and examples of that. And then we'll talk about challenges and difficulties, and then looking forward. The part going through the U.S. healthcare market issues and emergency room services, that's never fun. I'll say every time I talk about the problems that limit free market solutions, it's like getting kicked in the stomach. But there'll be a positive ending, so that's great. So why would Dr. Smith have an emergency physician talk at FMMA? And in fact, when he first proposed this, I thought it was a trap, right? I was like, every time at FMMA they talk about emergency rooms, it's never a positive feeling that I have after I hear the comments. So, but Dr. Smith's very, very, very intelligent, and I could see what his point was. If he could show that even emergency room care, which, like I said, is often attacked as why the whole movement or free market solutions don't work, if he can show that really it's doable in that setting, then he can maybe detract some of that narrative against free market solutions. So I see what you did, so I appreciate it.
Absolutely.
I'm very excited that you have to listen to me for 20 minutes. Okay, so let's look at the problem. So This emergency room, it says there will be a wait while we figure out your market solution to your problem. That's kind of sad, but. Okay, so what is the problem with free market, or what is the free market problem with emergency room services? I'm going to go through them and actually agree with or explain my perspective. I help manage a lot of acute care settings, OCMED, urgent care, but my model and what allowed this solution at OKER and hospital is everything that I participate with is 100% physician owned. And it is mostly owned by the physicians working at the facility, right? But I can help with the management of it and getting the group together. So I have a lot of different perspectives, and I think I was very blessed to be in Oklahoma City because Dr. Smith's progress there, as well as Jay Kempton, they were both very influential. I was working clinically, being able to see what they did. And that, I think, gave us the confidence to be able to implement some of these things you'll see. And then I do want to thank also my administrative team. So it's Judy Farm, our CNO, and then Chrissy Carter, facility administrator, and then Michaela Dillon, who is our business development. Okay, so the claim that's used against this, against the free market principles and the emergency room is that it breaks down. The free market principles are not possible, and the reason why is they say it's a distorted market, and arguably it is. It's for me, the difference between the real price and the charges is a direct correlation of how distorted something is. And it's the most distorted for emergency room services. We'll go through some of that. And it highlighting that concept. So another thing, as people get deeper into emergency room problems, is that, someone goes to the hospital and you have, you get a fee for the hospital, and then you get a fee for the emergency physician. And that's been decoupled for a number of issues over the last couple decades. And that allows for more distortion, and it creates the issues you've seen in the news, like balance billing, surprise billing, those things. So that movement for a hospital to allow that physician who's doing service there to not be tied together with their pricing, it's an economic decision. And by doing that, they created that movement, or that factor has made it worse. Out of network, balance billing, surprise billing, right? That's whenever anybody thinks about emergency room care. We, by principle, don't do balance billing. We are out of network though. And so that gives a unique perspective on the market. Unpredictable utilization of services. So if you're an employer and you want to contract and bundle, how do you know, someone comes in, how do you know what they're going to need, right? Can you plan it out like a surgery? And that's an argument against being able to do free market principles in emergency room. And then emergent service and the services being provided before payment, right? How do you shop if you have to emergently get something and that's going to be provided to you, and then the payment's 3 to 6 months later, right? That's kind of almost like a gun against your head or extortion, right? So let's, and I agree with a lot of those problems. I mean, that's what drives me to want to do more transparent or free market solutions. So let's talk about the problems with the U.S. healthcare market from my perspective, and then the emergency room service, because I think it'll give kind of the picture of how we found a solution. So I label the U.S. healthcare market as a perpetual absurdity, and I think that's pretty generous if you talk about it. I think I could have a much more vulgar title, but it's crazy. I mean, we talk about all these major issues. They're counterintuitive to common sense, fairness, and despite good ideas, good plans, it doesn't get implemented, right? the solution is often stalled for a number of reasons. So let's go through what I see as some of the biggest problems that has made emergency services so distorted and seen as not being able to be bundled. So the employee benefit model with the non-fiduciary middleman. I'm sure if you participated with FMMA, you've heard that, when the U.S. government decided to make insurance a tax benefit through employee service or employee health or through the employer, that really kind of distorted things, and it took away a direct to consumer fairness, right? And it causes a lot of distortion in the system for a number of reasons. And so I do think that if insurance could be decoupled from an employee benefit exclusively, then people or patients would be more in tune with, the cost, the expense, the quality, the value of the service. But unfortunately, when it's tied in that direction and people are brokering something important to all of us, it creates quite a few of the problems. So that's one of the earliest issues that has created the problem we're dealing with. Then CMS rate setting and regulation. I think we can argue that CMS by concept is a good idea, safety net. But unfortunately, from its onset, it's a tumor. It's going to grow, and its influence on the market is felt, I think, in every setting. And they're not tethered to a fair market. And so when CMS sets a rate for a certain type of service, it's going to leads to cost shifting to other patients or other carriers, right? And that's not fair. And that creates a lot of the problems we're dealing with. Unaccountable bureaucracy. So whenever we do have a solution, Jay Kempton was just talking about the No Surprise Bill Act, and I agree with him. There's some issues in that arguably could be great. The problem is right before it gets implemented, when it goes through rulemaking process with the departments that are supposed to implement it, it gets extremely broken and distorted and vague. And when you have someone has a interest in a special interest or bias that's involved in the process, and they're not elected, it creates a lot of problems that we're seeing. So then regulatory and legislative power. So in the large entities like healthcare conglomerates and, the BACAs, the large carriers, their power for legislative to do things like make a law that's supposed to create transparency vague purposefully, they have that power. They have that regulatory and legislative power to influence it. Okay, and then ERISA. So often when we look at these problems and someone who wants to fix them or hold someone accountable, whether it's the carrier or where it gets stuck is that ERISA basically prevents accountability in the court system. So if I have a carrier who is specifically doing something, not applying the patient's benefits or denying it or shifting all the costs to them, and I want to represent the patient, it gets preempted as an employee benefit to an ERISA pathway that has no recourse, right? So you have something that would over time help fix, naturally, all of the problems we're discussing would have solutions, right? But there's limitations on the solution. ERISA is a big one. Okay, so control of the media narrative. So larger entities can really impact what the general consumer understands. That creates more distortion. And then self-employed ASO plans. So this will wrap up the U.S. healthcare problems. And I'm a big proponent of self-funded employer plans. The problem with an administrative service only plan through a large carrier is that it is borderline fraudulent. And, when the carrier has a flat incentive of 15% for everything they pay out, you think they have an interest of negotiating or doing what's in the best interest of the employer? So, ones that are in a fiduciary relationship, maybe, but for the most part, no. And it leads to just absurd abuse. And I see that every day. I'll have a carrier whose plan will pay, $57 for a COVID test when it's a fully funded plan. And then that same carrier will apply a self-funded ASO agreement to that patient, and they'll pay 100% of inflated charges. That doesn't make sense, and it's quite abusive. So the emergency room CMS rate setting, I talked about that earlier, but for the emergency room, I will say that my perspective is that it is CMS's rate is low, and so what you've seen is shifts and distortion that hurt the general consumer and patients who have commercial insurance or are paying cash, and then not being tethered to the free market, it's cost shifting onto the rest of us. And what has happened too, on top of that I would say not everybody realizes, is that hospitals who have the ability to make their own coding guidelines for the facility side, where a lot of the expense of a ER visit's at, they have shifted to adjust for the low CMS rate for services. And what I mean is they get to determine what resources used apply to a level of an ER visit. And that's where a lot of the expense for the ER visit is. And so if the rate is low and distorted and not fair, well, guess what? They make the codes higher. And then that leads to more cost for everybody. It's multiplied for private insurance. And they know this. I mean, MedPAC talks about not having a standard codes for the facility for a decade. So then emergency room issues, you got an unfunded regulatory obligation, right? So you have to see all the patients, irregardless of whether they have the ability to pay or will pay in the future. Well, guess what? That's more cost shifting. But for us in emergency room care, that's why we went into it. It wasn't about this or that insurance. And so we understand that. But the reality is it creates more expense. Someone's going to bear the expense, right? Patient responsibility levels. So for the emergency room, high deductible plans, they make sense. It's been a solution for a lot of employers. It's something that I think is generally liked by FMMA. From my standpoint, when we apply emergency room services, the high shift to the patient responsibility, so high deductibles, it's led to even more inflation of prices. What I mean is, when a teacher, they're a great concept, but when they're not coupled with a HSA and you have someone who's paycheck to paycheck with a $4,000 or $5,000 deductible, that hospital is not going to get paid. And so as you shift more high deductible plans for ER care, then what ends up happening is the price shifts even more. Obligation to charge the prevailing rate. So the way I want to be transparent with prices, right? And I want to be clear, there's a difference between charges and the costs, right? The cost is the actual price and the charges are very comparable to monopoly money. But why are they assigned to the service? Why do entities, charge this absurd charges, this charge master that's not tethered to a real price, that's inflated in some cases 1,000% of what the true average price received will be? It's because the way the private market reimburses services. It's by design over time, and it's been perpetuated and continued. And what I mean is, a lot of carriers pay a percentage of charges, right? And so if you want that average charge, you have to adjust that average price, you have to adjust the charge. If you put the true price, and they're still going to pay a small percentage of the charge, you're not going to be doing this very long. Variation in reimbursement rates. So, as I said earlier, same carrier will pay $57 for one test, or for a test. Same carrier, different policy, different employer, will pay $1,000. That's absurd. Same carrier. So the institutional E&M levels I discussed, staffing companies, balance billing, surprise billing for emergency rooms. So I talked about how the professional and the facility side are decoupled. Well, as what's happened in emergency room care, as it's been hard over time, it was harder for emergency physicians to make a fair wage. So they've been forced into staffing companies instead of being the employee of the hospital. Because if they didn't, the wage they made was not acceptable. And so the way to do that was through staffing companies, which participate in balance billing, and surprise billing. And when you decouple and you have the emergency physician through a staffing company, and the patient doesn't realize, it creates a lot of the news headlines we've seen. The Affordable Care Act. So I'll say that the Affordable Care Act maybe had some corrections in it for some of these problems. It protected emergency room services. It became a protected service. Unfortunately, they left the regulation very vague, right? So you can go anywhere, you use your emergency room services. It doesn't matter if the physician or the doctor is out of network, and that was the intention. But when it came to actually implementing it, they left it vague. They said, you know what? Yes, your benefits are good, but we're not going to tell the carrier what they have to pay. What is a fair payment? We're going to define greater of 3. So median and network rate, CMS, or whatever formula that insurance company wants to use. That's not a way. You can't implement that, right? First of all, median and network rate is proprietary information from the insurance carrier, but that was their solution to correct emergency room care issues. But obviously, there's no real opportunity or solution in that. No Surprise Bill Act has some corrections with no balance billing. For my entities, we don't balance bills, so it doesn't. It's something that we actually look forward to, because if consumers are not worried about balance billing with out-of-network emergency services, that's a huge detractor of why they may not want to utilize our facility, because of the narrative they hear or the thought that they will have more expense. And so if that's fixed, in principle, that's great for us, because we know our facilities are more concierge, less bureaucracy, leaner management, physician-owned and directed, looking to provide the best care and medicine possible. And so we know we can outcompete based off service. So that, in principle, would be great. Unfortunately, it's looking like same thing with the Affordable Care Act. They need to define what's actually going to be paid, right? What's fair, and they are leaving it very vague on purpose, not defining a standard or tethering it to the free market. So examples of a solution of all these problems, right, is things that Oklahoma ER and hospital are doing. So we have made a commitment to price transparency, specifically for the cash pricing. And we have outpatient services listed on our website. We provide that to the patient if they'd like to use that option. It's a fair, transparent, easy to understand pricing system. We do bundled pricing for the emergency room service, and I'll go through those examples right now. And so a low acuity, a patient will know that this is what would be paid cash-wise, and higher acuity, this is what they would be owed. This isn't difficult things to do. It's common sense and fair. It's just for all the reasons I talked about earlier, all those problems, there's been a inertia to not do this, right? To play in that system. And so we're looking to be out of that system. Direct contracting with employers. So we do that. A lot of the direct contracting is reference-based pricing, but it's transparent, and you have an employer who either has a TPA or is directly reaching out to you that's self-funded. We can give them common sense, easy system for reimbursement, right? Where there's an incentive to use our system. They don't have to worry about balance billing, surprise billing. It's straightforward. This is our online pricing for a lot of services. So you'll see that we do CT, ultrasound, MRI, labs, x-rays. This is the cash price. So if the patient pays for these, wants a service at our facility, and has a order from a referring doctor, they can get these services really quick and really efficient. Direct primary care referrals, that's a huge part of our facilities patients, the direct primary care. They're value-based, the referring provider is value-based, they align with what we believe, and so they'll utilize this because of the common sense solution. It makes sense, it's easy, it's predictable. Okay, so I want to give you an example of our bundled pricing for emergency room care. And I want to be clear, we'd love to be 100% based off of this. That's where, and we thought we would accelerate here quicker, but we're dependent, having to take care of any patient who comes in, we're still dependent on the private, traditional commercial insurance. And we hope over time we're less and less, and that we can be exclusive to this type of model, because we enjoy it. It's fair, it's transparent. So based off the level of services used, this is the self-pay, this is the cash pricing. This is provided to the patient. We used to have this online. What ended up happening, similar, I think, to what Dr. Smith had, was insurance, some carriers were taking our charges and saying, well, actually, your online price is that, and that's what your charge is, and so it was creating quite a bit of issue. And this is 3 to 6 months after a patient received service. And so they were using the price transparency against us. And that's what a lot of hospitals, I think, fear, or a lot of providers fear. So level 1 through 5. So a relatively sick patient that needs a belly CT, like an abdominal CT, maybe they have appendicitis, IV fluids, labs, everything, evaluation by the physician, treatment for the pain, et cetera. That's $1,500, right? If patient uses this pathway, there's no future bill. It's done, right? It's easy. It's common sense. That's a really sick patient. A lot of the visits are at a much lower price for emergency room services. Level 6 includes when we observe patients for longer periods, up to 23 hours for service in the emergency room. So we do, our facilities, we have inpatient care, but we really enjoy being able to minimize admissions if we can for inpatient, and keeping a patient in observation status, having a physician close by that is routinely reassessing, managing, and really putting a lot of effort into getting them fixed or home quicker, rather than parking them in a hospital to meet the criteria of an inpatient stay. So the observation service does that. So what has been the challenges with this system? So the traditional pathway, we're still dependent on that. Revenue cycle management team. So because we're dependent on the traditional pathway, my revenue cycle management team is used to the traditional carriers and collecting and going through that process. So I will say they're a little rough for this common sense pathway, right? The customer service part of it. And that's been a challenge for us, because that's the feedback we get, is that, hey, like, why your billing company, why are they speaking this way or doing it in this way? And it doesn't make sense for people who are looking at a free market, right? Because so that's been a challenge for us. Uncompensated care, right? So the more uncompensated care we have at our facility, the harder it is to have fair prices like that. Unnecessary utilization concerns. So one of the challenge we have to implementing this is Employers, if you make too good of an incentive, if it's like we have a direct contract and the patient pays nothing out of pocket because they choose our facility, and we have those type of agreements, the concerns by the employer is that, well, it's too good of an incentive, and I don't want them utilizing the ER for things that they could go to more appropriate levels of care, and that's a fair concern. So we've made some changes for certain employers and contracts to account for that. If it's a really low acuity visit and it could have been served somewhere else, the patient bears some sort of risk reward, right? Federal and state regulations are ever changing. Hostile market in Oklahoma for the insurance carriers, additional services, and then special interest power. And what I mean is that goes to the regulatory and legislative issues. Okay, so looking forward, we want to get to bundle pricing first, traditional insurance second. We want our free market population to be a majority of our volume. We want complete price transparency, additional regional facilities, grow it, more bundled payments for traditionally with TPAs, our system will do more reference-based pricing, but the bundled payment system makes sense. And that's where we want to go with TPAs as well. Expanding service lines, so additional services, fill the need of the community and the referring physicians. So do you need infusions? What do they need? Because we can add it to it. Just like Dr. Smith, they can call them and tell them what they need for this surgery or that. And so we want to expand those, integrating urgent care to address the lower acuity issues. So then the question comes, is this solution reproducible, right? Why? And I would say yes. I say it dispels the myth that you can't do this in emergency room settings, which is used wholly against the free market idea, right? It's just a very aggressive argument against free market. And so I think this dispels that. Is it reproducible? Actually, it absolutely is. I mean, it's common sense, it's fair. We do have the benefit of being in the backyard of a very mature free market in Oklahoma City because of the work of others. And that makes it easier to implement, but that doesn't limit other entities from doing it. And I would say we're independent and smaller. Each facility's individual that I represent. And so there's not a lot of power there. There's not a lot of legislative and political power. Imagine if a larger entity that doesn't have to worry about the carrier playing this game with their price or that, or has a better position. Imagine if they wanted to implement it. They could, and they'd probably be able to do it more successfully. And despite that, we're transparent with what we're doing. And it would be very easy for a larger healthcare system to do this. I just think that it's easier for them to play in the current system and game they're in. There's more profit. The distortion is to their benefit. It's too profitable for them. And so switching to this, they don't want to get away from their CMS base, or they don't want to get away from their commercial insurance contracts, right? They don't want to provide a transparent option because they're dependent on those for their income. But I think there's ways to slowly transition this to be more transparent, to offer these solutions. And if enough employers seek it and enough people know about it, then over time there's going to be no option but to move to do things for this type of patient who wants this as a solution. So any questions, any specific questions that I can answer about this model and some of the solutions I'm discussing? Okay, go ahead.
Hello. So when you enter into an agreement with an employer, you mentioned this, and I think I got it, but are they accessing the prices that you have for self-pay, or is it different in that they're accessing a percentage of Medicare?
Both options exist for an employer. A lot of our TPAs are through reference base, which is a percentage of Medicare. Even though I said it's a distorted value, it's kind of something that it's the best we have, even though it's crap. But with employers too, we will do directly with the employer if they want to do the self-funded bundles, we will do those with that. But the idea behind that price being fair and low is that we receive it consistently, right? If we have to average over lots of patients where we don't get paid, it doesn't work. It's not sustainable. So when we do a contract with directly with an employer, it'll be pretty much, if they have that service, it will be invoiced and it's almost 100% successfully paid within 30 days, right? We have that type of agreement for it. So some of them will want that because they want more, to have it referenced to Medicare that has thousands of codes. If an employer is really trying to understand it, it's not very easy. So we do have direct contracts with that. Some people, some employers that don't have, maybe the size of their organization, or they don't have, employee health insurance benefits, they will enter into a contract for that payment price too, and refer their employees to us and pick up the tab. Okay. Right. And then avoid the whole commercial insurance. That's probably not a solution for most employers, but that's how some use it. Yep.
And with when you said that the insurance companies, they got a hold of your self-pay prices, and did they pay a percentage based on that, or were they paying that? Or
no, they paid. What they did is they took that price and then applied the policy, the plan, and then they said, okay, well, the patient has a $4,000 deductible. The price was $1,500. Go get that $1,500 from the patient, okay. Right? And one of the difficulties not everybody realizes, the ability to collect a patient's deductible and responsibility so far after service is really low for all hospitals for emergency room care. And that jacks up the price even more. It's under 20%. And employers think that they're going to get that, that's part of the payment system. But in emergency room care, the reality is it's not, right? And so that whole incentive really breaks down, and it's frustrating.
Thank you.
Okay.
So the CEO of my local hospital said to me in a meeting that emergency room care could not be done this way, and she's kind of snippy about it, so I'm really happy to be able to go back and correct her. But in emergency room care, so many of these staffing companies that are famous for upcoding. I think, and I really hope that that's going to be outed here really soon. But I caught one of them on a webinar. I don't know how I got invited to a webinar from a ER staffing agency. I don't really get how that came up in my inbox, but it did. So I looked at the webinar, and they basically inferred that when the surprise billing rule comes effective on January 1st, that's really going to throw off their P&L. And one of the ways they're going to have to pivot in order to balance their P&L is to replace emergency room physicians with nurse practitioners and PAs. Can you give an opinion about that?
Yeah, we're already seeing the effects on the emergency room market. One thing was that the narrative of the balanced billing really hit in the media aggressively in the last 1 or 2 years, and that has changed it, where a lot of staffing companies now have chosen not to balance bill or try to go in network now, or the hospital has demanded it, which I think they should have done in the beginning. But what it's done, every time there's a small adjustment or a fix that's regulatory, there is downstream distortion or effects. Okay, typically large systems are going to be able to benefit most from when there is a regulation, right? And so for the emergency room, what we've seen even during COVID, which is national emergency, and we won't get too much into politics right now, but even during COVID, emergency rooms were cutting their emergency room doctors, replacing them with mid-level providers, and emergency room doctors as a whole saw their salary go down by about 30%. So you see more pay. So it's destroying the quality, right? Because they're getting paid less, and they're seeing more patients, right? Because you're cutting the staff, and it's just one of those market shifts, right? And it's unfortunate, but yes. And I definitely think that whenever there's so many absurdities like you're talking about, like this group of doctors talking about shifting this or that, and the coding. But every time there's a regulation that is not tethered to free market ideas or solutions, it's not manageable. And there will be a distortion downstream. People will take advantage of it and do what they need to do to survive, right? Whether that's a large healthcare system, an insurance carrier, the physician, they're going to adapt, right? And it's just adding more crap to a crappy system, you know. But I am passionate that the solution is not universal care. That is, you know, I think we find ourselves too often defending the status quo, even though we all understand the free market solutions are what the solution is. But unfortunately, it's like a false narrative, in that people say, well, they attack the current system and say, well, the solution is a universal system, right? And then we find ourselves defending or being forced to say, well, it's really not that bad. And really, I don't think we should defend it, right? The solution, we kind of agree, right? Sometimes on that no, what's the status quo right now is not acceptable.
I think if you had completely lost your voice,
Mm-hmm.
we would just put this slide up.
Yeah.
I mean, the whole concept of taking something complex and making it simple, I mean, this slide, it's, well, you don't know what all they're going to need. Okay, then you have tiers. We've done that on our website for like pediatric dentistry. I mean, we don't know how many teeth are going to have to be dealt with by the dentist, so we just have tiers. And when the surgeon examines the patient, they decide what tier they are, and that's the price. So this is a beautiful slide. This is my favorite slide of your whole presentation.
They help make it.
This is wonderful. Yeah, this
that
is great.
form and systems.
Christian, we have a question from our online viewers.
Okay.
Dr. Artie, she said, can ICU bundle payments?
What's that?
Dr. Artie asked, can ICU bundle payments?
Can ICU bundle payment? Oh, ICU bundle payment? That's going to be hard. I mean, I think this is scalable. An ICU bundle payment is you know, the amount of services and the time, those variables make it hard, right? To do bundled payment in absolutely every service, but the same concept, right? You can make it based off days, or you can make it based off of services used, and make it simpler to pay and to follow and to understand what it's going to cost.
We paid Deaconess a per diem rate for ICU. They had a per diem rate for, you know, a regular bed, and then they had a per diem rate for an ICU bed. So they figured it out. But it's a whole concept of, you know, do we have to win every single, you have to score a touchdown every single time you throw a pass, or do you just look at your cost? And again, in an ICU, just like an emergency room, most of what's going on is covered by the fixed cost. If you add 6 more patients, all you've added is really the cost of the supplies to take care of them, because the capital cost, I mean, it's already there. So yeah, I mean, we absolutely had a fixed rate for ICU. Yeah, and you guys sort of do that with us. I mean, if we have a patient severity, then you all.
Right. And you can do it by days, right? You can have a rate based off days, and we do some of that. Like if someone needs longer care.
So I had a comment and then a question. So the comment is, you know, if you have a large enough population that you're dealing with, obviously for emergency room services, the population is going to normalize towards a mean. And so you really could theoretically put a bundle together that is going to work for that group. It's just on the individual market where there's so much variability that you really come into, those levels 1 through 6 really come into play. But for a large enough group, really a flat price across the board theoretically could work. But then you look more like an insurance company.
Right.
So I understand. But if the self-employed, company is already assuming the role as the insurance company, that it doesn't really matter. So if you theoretically, like you said, I think you already are doing some bundles. The question is then, what sort of barriers and incentives do you put into the plan to sort of drive behaviors and to make, smart decisions to get the care at the primary care versus at the emergency room? So that's sort of the comment. And I guess the question more to the Atlas billing side of things, because I've tried to negotiate prices with various hospitals. And so when I work with a hospital that employs the anesthesiologist, that employs the radiologist, that employs the phlebotomists, a bundle is easy. I mean, we can get a price because it's one payment and it goes to the hospital. But the larger hospitals where the radiologists are independently contracted in billing, the anesthesia is independently contracted, the hospital doesn't want to shell out and write out 16 different checks and have to deal with that. So, so is Atlas essentially functioning as a TPA that then does things on an extremely granular basis where you're taking that headache and hassle out of that? Is that how that works, and how's that structured?
That's exactly right. And the hospital actually has real anxiety about writing checks to people who work there, so who are not their employees. So yeah, I mean, that's exactly what we do. And we've gotten to where I can pretty close guess what the anesthesiologist is going to charge for a 2-level spine fusion or a colon resection. And we'll actually quote a price to the buyer without actually knowing what everyone is going to charge up front, because we've gotten pretty good at getting close enough that when the buyer says yes, we can give the green light. And then when the anesthesia bills come in, or the radiology bills come in, or the hospitalist bills come in who are not the employees, then we're pretty close. So it's a bit of a gamble, but as a clinician that runs a surgery facility, I mean, I can do that. But you recognize patterns, and I mean, there ought to be 100 Atlas billing companies out there, and there will be. But yes, that's exactly what we're doing. We're creating the bundle that the hospital cannot create or implement, and then we implement it.
Hi, thank you so much for your talk. My question has to do with, flexibility you might have since you're a more, independent emergency room service. And I'm wondering if it helps keep the price down if you have the, the flexibility not to have like the fanciest emergency room. So my emergency room is Presbyterian Dallas, and it feels like going to the Ritz-Carlton every time I go. And I just wonder if it helps, if you have anything to say about cost containment in terms of, facilities. Of course, like infection rates and stuff is important, but do we need chandeliers and things like that?
I think that's a good point. Is there excess that's driving up the cost? I'll tell you that the emergency rooms, for a brand and to generate a great experience for patients to come back, yes, they are very, very nice, and they're new, and they have chandeliers or lighting, expensive lighting. From our standpoint, to the expense in staffing a doc 24/7 and a nurse and a tech and multiple personnel, and they're very expensive each month to run. They're above $500,000. And so I don't think that there's a big factor that gives us a benefit to lower the cost. We have very high overhead, just like any other emergency room. And we don't have a lot of places to shift expense, right? We don't have some of the more profitable drivers of a hospital. right? And so that's, I understand the comment that maybe we're more flexible because we're independent and don't have some of the other hospital expenses.
Yeah,
But-
like buying out physician practices and buying ads during the Super Bowl and
Right.
buying out competitors.
That's
and
a good point.
yeah, it's ridiculous.
But valid point.
Yeah, and Lee, to your question too, a more complete answer, I think, is that we're doing that for facilities that exist in self-funded markets where no hospital wants to do it. And part of the reason they don't want to do it is they can't implement it and they really don't know how to do it. So for all of you who are in the world with price gouging hospitals, and that's all you can see as far as you can see on the horizon, the tool is there for them to be in this bundled world. And Atlas is one tool, but there will be many, many, many more because it cloaks them from the carriers and it just does all those things.
In the Clayton Christensen book, The Innovator's Prescription, he talks about the decentralization of healthcare. And it seems to me like an emergency room that's thinking the way that you are thinking is bound to start thinking outside the emergency room, where so much of emergency room visits that I've seen have been unnecessary or not necessary to handle in the emergency room, where the cost of the facility is way up. Is that something that you're looking at, moving emergency care outside of the emergency room at all?
I mean, like on my slide, we look at integrating urgent care. There's been a lot of entities that have done that or tried to do that. So, that's challenging. I will say that it's a lot of the distortions that make the emergency room care, especially the charges, so, and with the narrative you're saying. But when you look at like a urinary tract infection for CMS, depending on how the facility and the doctor code, in an emergency room, that might be a $400 combined payment from CMS. In a urgent care or a clinic associated with the hospital, $220, $250 range. In the private clinic, $110. So it's actually, that inflation is not, yes, there is a lot of savings, and going from the emergency room care down to, the hospital-based urgent care, and the best savings with the, clinic setting, but it's actually not like a kick in the stomach, right? In the private market, in commercial insurance, it becomes a kick in the stomach because every factor inflates it. Everything, all those distortions and problems multiply the difference between the charge and the actual price, right? So you go into an emergency room for something that could have been handled outside somewhere else, and you could see a $10,000 charge for something that you could see a charge of $250 or $200 in a clinic and pay about $110. That is scary.
And
so we are looking for, but our facility, what we've done instead is we've expanded mostly services. The physicians there are partners. That's what drives it. That's that's part of why we are okay with this plan, or how we get the doctors engaged into it, right? Because most traditionally an emergency room doctor, we're not very economical in medicine. We don't get trained in this, right? We handle emergencies, right? I think there's other specialties where there's a little bit of financial training, zero in emergency room care, right? But once their partners are able to kind of make some of these changes, and that's a huge driver. But we do outpatient services that we do additional services at our facility, right? And use the hospital license. So there's inpatient care. We take direct transfers for that. It's not all hospital, ER-based care. We do like MRI, I think any body part MRI cash price is $325, right? That's we do those types of things. We do like 100 of those a month. There's a lot of those services, but as far as like, integrating lower levels of, or like primary care into it. We've looked at it, you know, traditionally primary care is going to be a referral entity with our overhead.
And what about discharged with IV antibiotics at home instead of in admission to a hospital?
Yeah, we have been talking about infusion teams and putting in PIC nurse, PIC line. We've looked at that and providing some of those services that are common sense, save money, right? We need enough employers to drive the demand, right? Because you can imagine taking the risk in it and not having anybody show up, right? It's a lot of an expense. And so, but yes, there's definitely a lot of things that can be delivered more efficiently at a much lower cost, and they should. And when you get people out of the broken, distorted system, I think you'll get more and more solutions like that. I will say earlier, the comment about, you know, the hospitals that send radiology or outsource radiology and stuff, should that have been tolerable by a marketer system? No. I mean, that's highly inappropriate how that has rolled out. And if we didn't have all these regulatory things that distort and make it opaque, I think common sense patients, consumers would not have tolerated that, right? It's the power they get in that distortion, that opaqueness, that allows them to make that economic decision, which is very, very harmful to the patient, confusing. And they're allowed to do that. Is that appropriate? No. And why did it happen? Why? I mean, any other, you know, industry, that would not have been tolerated, that movement, because it was all economic gain. And especially, you know, the health system's decision to move those things. They're like, you know what? That's a really expensive, you know, provider. That's part of our overall what we're doing. Let's just push them out, let them, you know, negotiate. Let's not pay him directly so we can negotiate our part, and we'll let them on the side, right? It doesn't make any sense. So I just wanted to bring that point up. You know, it is going to be difficult, but that health system has already declared themselves. It's probably, I guess, Dr. Smith could look at that and say, well, that's going to be harder to get, you know, a bundle through. But I mean, they made that economic decision. It's almost a red flag for me.
All right, we have time for one more question. We have 3 minutes.
All right. Dr. Rice, the last question you had was more clinics like yours.
How do we what?
How do you get more clinics like yours? How do you get ERs like yours? And having been to your clinic, and I send people from all over Oklahoma City to it because I love it. It's the whole chill feel of it is so de-stressful. And but when I talk to DPC practice doctors, the one common theme they keep mentioning is they're practicing medicine like they dreamed they would back when they went to school. Getting the money aspect out of it, and they're practicing medicine again. It's got to be a change of the heart. You got to find some place, like a guy that has a heart like Keith Smith that years ago said, okay, we're going to do this on a reasonable rate, and it's going to be practical, and we're going to be transparent about it. That's the question. Like, for instance, you and I talked one time. You may not remember me. We had dinner, and we talked about moving a clinic to Norman, Oklahoma, where I live. And you were talking about the impediments that the city council, who actually owns the hospital, wouldn't let you put a clinic in my city. Okay, so there's definitely those type of impediments, but somewhere you have to appeal to someone's heart and say, look, you say you're a nonprofit organization, theoretically, okay? How about we try to, you know, I think that's where the appeal has to lie. There has to be a change of heart, because clearly, just hearing you guys talk, you're about treating the patient, and yeah, you got to cover your costs, but you don't need to price gouge anybody. So if my 2 cents worth is somehow, how do you do that? How do you appeal to somebody? And I'm going to ever take a Baptist and turn them into a low-cost provider. Too much infrastructure, too much overhead. It's got to be a smaller place like yours that comes up from the bottom and services the community.
I'll say I think it's demand, right, with the consumer. So the employer wanting that, driving that. I think being aware of it. Those are all keys. I mean, I really felt like we would be further along towards a majority free market volume. those variables have made it harder. It's a very hostile market for us with the traditional commercial route. And I have great stories that anecdotal issues I can explain that has made it challenging to like spread to another facility. We have Tulsa ER and hospital. That's our second one in Oklahoma, but we'd love to put more around the metro. Maybe it's a different level. Maybe it has urgent care or primary care integrated into it. But we have some external challenges, and so this hasn't progressed as quickly as I would like. And especially dealing with those external challenges, it's it hits our PR and challenges for the team, and it's made it harder to get in that direction. But I think with awareness is part of it, and the demand, because that's what things are driven on. So the more employers that say, hey, I want a Dr. Smith solution approach to this, right? And the more people who are out there looking for it, the more hospitals are going to have to provide it, or someone else will, right? It's just very slow because of the distortion of the system, right? It hides progress quite a bit, or cancels progress.
Well, let's thank our distinguished speakers, Christion, Dr. Smith, and Kylie.
Yeah, thank you.